Dr. Greiner?
Yes.
Hey, thanks so much for joining us.
You're welcome. Sorry I couldn't be there in person. I was kind of excited. I've never been to Ames.
No, I was going to say, I commend your good common sense. It's not very nice here right now.
Well, I was in Des Moines on Sunday, and after all the tractor trailers I saw in the ditch and in the median, I thought it's probably not wise to drive.
I would concur. I'll get you started here.
Okay.
Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and then also please remember to fill out the program evaluation, including the part regarding future topics and future speakers. Due to the inclement weather and through the marvel of modern technology, today I have the good fortune of introducing Dr. Andrea Greiner. Dr. Greiner is board certified in obstetrics and gynecology and maternal-fetal medicine. She wears several hats at the University of Iowa. She's a clinical associate professor in obstetrics and gynecology. She's the director of OBGYN telemedicine. She is the division director in the Department of Maternal-Fetal Medicine, and she's also the director of the Maternal-Fetal Fellowship Program. And we're quite pleased that she was able to join us remotely today. And please join me in welcoming Dr. Greiner.
Thank you so much. I'm happy. Sorry I'm not there in person, but hopefully I'll do a good enough job that you'll invite me back at some point. So I'm going to go ahead and switch to my slides. Just want to make sure that you guys can see my slides there on the screen. I'm going to assume that means yes. So when I asked what topic you wanted me to cover, I was told that you wanted to cover complications in the perinatal period, which is kind of a broad topic. So I took a little creative license and picked some things that we, patients that we have cared for here in the last year, all of whom were transferred to us from hospitals similar to yours. So I thought it would be a good place to start. So the learning objectives are listed here on the screen. I'm going to talk about a few select medical complications of pregnancy, talk about how to evaluate and manage them in the acute setting. I want to inspire all the OBGYN people in the room to be a confident consultant to your non-OB specialty physician friends, and also to recognize when you have a critically ill patient and decide when to transfer them to a higher level of care. I'm not trying to steal all your patients. I'm just trying to help you guys make good decisions and continue to deliver the great care that you already do. So these are the 4 topics I'm going to cover today. These are all patients that we cared for within the last year here at the university. A couple of them we had more than one. So I thought it would be some relatively rare things in pregnancy, but still some things that are important topics that you need to be able to recognize. So these are very important topics, I think. As you all know, our pregnant patients are getting more medically complex and have higher risks of morbidity and mortality. And it's all due to those things in the blue circles on the bottom. More of our patients are older, they have more hypertension, diabetes, and obesity. And this impacts their medical risk factors in pregnancy. So the first thing I'm going to talk about is stroke. So in each of these topics, I'm going to start with a clinical case just to kind of frame the discussion moving forward. So this is not a patient we cared for in the last year. This is somebody I took care of a number of years ago, but it was a pretty dramatic presentation, and so I like to use it. So this was a 37-year-old female, first pregnancy, who presented to our labor and delivery at 37 weeks, complaining of a right-sided headache. It was the worst headache she had ever had, she reported. And as our resident physician was beginning to take her history, the left side of her face started to droop. And her initial blood pressure on arrival was 171/99. So our concern was she having a stroke in the context of preeclampsia? So stroke is a relatively rare occurrence in pregnancy, about 30 per 100,000 pregnancies. Pregnant women or postpartum women can have a stroke of any flavor, so either hemorrhagic or ischemic or due to a central venous thrombosis. Most of these occur in the peripartum or postpartum periods, and the incidence correlates with hypertension and history of cardiac disease. So risk factors to think about: a woman who is older at the time of her pregnancy, if she has a history of alcohol use in the past, and if she has any vascular risk factors. And these are risk factors for vascular disease to keep in mind. If she has a history of migraine headaches, history of venous thromboembolic event, lupus, particularly advanced lupus that's affecting end organs significantly, history of sickle cell, hypertension, any heart disease, Pre-gestational diabetes, particularly if it's been long-standing, she was diagnosed at the age of 4 and now she's 37, she could definitely have some underlying vascular disease related to her diabetes and a history of thrombocytopenia. So initially manage their blood pressure as the most likely thing you're going to see. This is in the context of preeclampsia potentially. Here at the university, we have a code stroke, similar to like a code blue, that we are expected to call if we have patients who had symptoms for stroke. I don't know what the workflow is in your hospital. If you have something similar, or I know that our neurologists are always available through the stroke center here to help triage these patients. The acronym BFAST are signs potentially related to stroke to keep in mind if you have a patient with any of these. And time is of the essence. The sooner these patients are diagnosed and receive care is better for their outcome. So in pregnancy, you do need to image these patients if you have concern for stroke. CT is safe and appropriate in this setting. It is safe to give these patients reperfusion therapy if that is indicated. And I'll talk a little bit more about that in a subsequent slide. You can give these patients aspirin or low molecular weight heparin or unfractionated heparin too during pregnancy. If they're postpartum, you additionally can use warfarin. If the patient is breastfeeding or planning to breastfeed, you have to be a little choosy about whether anticoagulants and antiplatelet drugs you use. Most of them have very little or no breastfeeding safety data. A lot of them are pretty large molecules, so they probably don't cross into the breast milk anyway. But if there's no data, it's hard to, to prescribe those drugs if there's other alternatives available. So thrombolytics in pregnancy, this is a decision I haven't ever had to make, but I'm sure at some point in my career I will. This is relatively limited data, but from various reviews and case series, the complication rate seems to be similar to the non-pregnant state. There are reports of maternal death, bleeding, and fetal death. But you have to remember these are potentially life-threatening conditions as those listed there on the screen. And so there is risk for poor outcome anyway at baseline. And if this drug potentially can save their life or improve their outcome, then I think it's reasonable to discuss and give. So when to deliver somebody who's had a stroke in pregnancy, if you're certain that they have preeclampsia, you should get them stabilized and then proceed with delivery. If it's other causes of stroke, it will depend on their gestational age, what the patient wants to do, and where they are. In Iowa, there are some tricky nuances of the advanced directive law. And so if the patient has had a stroke and then is unconscious, even if she has an advanced directive, the way I understand it, as far as withdrawing life support, the law prevents that from happening. So this is one of those scenarios where ethics and legal and all those people will be involved as well. But I suspect by this point that patient will probably be in a tertiary center, but just to make you all aware of that. So the next topic is small bowel obstruction. And we've had 2 cases of this here in the last year. Like I said, both of whom came from the outside. So just a case example, 34-year-old patient, first pregnancy again at 38 weeks, presents with 3-day history of nausea, vomiting, abdominal pain. She can't keep anything down. She doesn't have any sick contacts or other infectious concerns, isn't vomiting any blood or doesn't have diarrhea, reports her baby's moving. Her significant history is the fact that she was diagnosed with Crohn's disease at age 23 and 2 years ago had a total colectomy and colostomy. And then 18 months ago, her colostomy was taken down and she had a reanastomosis. And the CT scan shows a transition point in the left lower quadrant with dilated bowel proximal to this point. So SBO is fairly common in pregnancy. I had never seen it until this year, so there are things that will surprise me on occasion. The highest risk is in the 3rd trimester, which makes sense because that's when the uterus is biggest and definitely has displaced the bowel. C-section by itself is not that much of a risk factor compared to other types of abdominal surgery. So patients who are most at risk for SBO are patients with a history of bariatric surgery or bowel resection. The causes for the SBOs are multiple. It can be just adhesive disease, or you can have intussusception, hernia, or a volvulus, or a mesenteric band. Most of the data on these cases is pretty limited as well, so it can be a little hard to draw any conclusions, but based on the reviews that I found, most of these patients ultimately will need surgery, particularly in the acute setting. This table is from a review article from England looking at cases in the literature of small bowel obstruction. And as you can see, most of the cases in this table had surgery. Most of them had their initial imaging study as ultrasonography, but then also had subsequent imaging by MRI, CT, or plain films. The gestational age range is pretty broad, and the etiology is fairly broad as well, but a lot of these patients you can see have had adhesions. This is another table from that same study looking at outcome. There is a risk, pretty significant risk of fetal loss in the cases of maternal small bowel obstruction. Maternal mortality is lower compared to the babies, but there is a risk of preterm labor, maternal sepsis, intestinal rupture, and death. So early identification and treatment of these patients is important to optimize outcome for moms and babies. So management initially obviously make these patients NPO since they can't keep anything down, NG tube to help decompress their bowel. Vigorous IV fluid replacement is important because they could be significantly dehydrated by the time you see them, particularly if they've been vomiting for a number of days. Treat them with an antiemetic and acid blocker. Labs, as you see there, if they're beyond 24 weeks, their fetus should be on the monitor. And then think about your imaging. I think most people would probably start with an abdominal ultrasound, which will tell you if there's dilated bowel, but it may not tell you where the transition point is or what potentially the underlying etiology is of the obstruction. A plain film will tell you where a transition point is, but isn't probably going to tell you about any adhesions, whereas CT or MRI will. The amount of radiation dose from a plain film or a CT is fairly low, and I think in these cases, potentially since this is an emergent type case, the small risk of radiation to the fetus is warranted. So then next steps. These patients will require a general surgery consult to help with surgical management. And then the decision point is, do they need an operation or can they be expectantly managed? And then do they need a transfer to a higher level of care? This is an algorithm from that same paper, and they basically divided these patients into stable or unstable. If they're unstable, they go to the operating theater. And if they are stable, then proceed to imaging and to help decipher the underlying etiology. If they have adhesions, you can potentially manage them conservatively, whereas if they have some of these other causes like a volvulus or an internal hernia, they are at risk for bowel ischemia, and that would require surgery most likely. So what does unstable or stable mean in the context of this study? This paper? Basically, a patient is stable if their symptoms get better with conservative management. You are relatively confident they just have adhesive disease and the fetal status is reassuring. If you don't have those things, then these patients probably need surgery. If they're not getting any better or they worsen, you are able to confirm hernia or volvulus, or even potentially intussusception on imaging, and or if the fetus is not in a good state. This might also be the point too at which you would transfer if your local consultants are not comfortable caring for a pregnant woman in this state. So the next condition to talk about is acute myocardial infarction. We also have had 2 of these in the last year, actually in the same month, which made it very exciting. So the case I want to talk about is a 35-year-old female, G4P3 at 38 weeks. She presents with acute severe chest pain, also reports she's short of breath and dizzy. Her history is significant for smoking and history of methamphetamine use, and 3 prior C-sections. Fortunately, her baby is reactive on the monitor. So acute MI in pregnancy is one of 2 common causes of cardiac death in pregnancy. The other is aortic dissection. Most women who have an MI in pregnancy have it due to non-atherosclerotic causes. I have a star by the coronary dissection, as both patients we had with MI here last year had spontaneous coronary artery dissections. One of them was near term and one was postpartum. So symptoms of acute MI will be similar to a non-pregnant adult: chest pain or pressure that radiates, short of breath, nausea, vomiting, diaphoresis, dizziness, or hypotension. They also potentially could be hypertensive. In women who have a history of diabetes, potentially long-standing diabetes, like I mentioned sooner, you need to think about atypical signs of MI. Is their chest pain of a different character? Do they also report indigestion or epigastric pain? Initial diagnostic evaluation in these patients, obviously they will need an EKG. You should draw labs to look at their electrolytes and calcium, as well as troponins. And you should draw your troponins every 8 hours thereafter to look for a trend. The troponins could be normal initially, depending on how soon after onset of symptoms the patient presents. It takes a couple of hours, my understanding is, for the troponins to increase after symptoms begin. If the patient has some other cardiac history, you may want to consider an echocardiogram and a chest x-ray. I think it's important to talk a little bit about normal EKG changes in pregnancy. I admit I'm not an expert in reading EKGs. Give me any fetal heart rate tracing and I'm your girl. But EKGs are complicated. But keep in mind that the resting heart rate in pregnancy increases about 10 beats. They can have some decrease in some of their wave intervals, but the morphology of the P wave, the QRS complex, and the T wave shouldn't really change. The axis of the heart can shift to the left, particularly late in pregnancy, due to the elevation of the diaphragm by the gravid uterus. So instead of the heart kind of pointing down and to the left, it gets a little bit more horizontal. And an isolated PAC and PVC in pregnancy is common and normal. So as you all know, there are basically 2 different categories of MI, either an ST elevation MI or a non-ST elevation MI. In general, pregnant women are more likely to have an NSTEMI than a STEMI. And so this is just to help remind me of what these look like on an EKG. And here's your ST segment here, which elevates above the line. Here's a ST depression and a T wave inversion for an NSTEMI. So I reviewed what the difference was, because I thought in case most of the audience was obstetricians, gynecologists, they might need this review as well, but maybe not. An NSTEMI usually means that there's a partial coronary vessel occlusion, which is why the waveforms look different. Their EKG could be normal initially, depending on how soon they present. These patients respond well to antiplatelet therapy to keep that vessel from becoming completely occluded, versus an NSTEMI where the vessel is completely occluded. These are people with long-standing atherosclerotic disease or risk factors for. The ST wave changes need to happen or be occurring, in more than 2 or more contiguous leads in order to be diagnostic. The STEMI patients are a little bit more likely to respond to reperfusion therapy and stent placement. So in the acute setting, first you want to assess your patient's ABCs. How is her airway, breathing, and circulation? Is she conscious? Then move on to the MONA acronym, which stands for morphine, oxygen, nitroglycerin, and antiplatelet. If you think the patient has an NSTEMI, you may want to consider avoiding morphine, as this can worsen hypotension. If the patient's hypertension, that can be treated with, has hypertension, excuse me, can be treated with a beta blocker or a calcium channel blocker. And then antithrombosis to prevent the formation of more clot in their coronary arteries. And obviously all of this you're going to be doing in concert with either an ER physician or a cardiologist, depending on where you are. So contraindications to some of these medications, this is where the medical management gets pretty tricky, and you will be very grateful as an obstetrician, or I am always very grateful for my cardiology and ER friends in these situations. So beta blockers are contraindicated if patients have any of those conditions there. If you suspect a right ventricular infarction on the EKG, nitroglycerin is not a good choice, as it could worsen hypotension and decrease their preload. Statins, there's very limited safety data in pregnancy, and for the most part, these patients don't have atherosclerotic disease, and so that's probably not a critical exclusion. And in general, we recommend not giving ACE inhibitors in pregnancy, but you can give them in the postpartum period, and they are not contraindicated if mom is breastfeeding. This is a table from one of the main articles I used, the Pacheco et al. Article about contraindications for the use of fibrinolytics. And I think I put this in here to show that it says pregnancy is a relative contraindication, but also to think about this in the context of somebody who is recently delivered. If somebody's had a C-section or a vaginal delivery, even if it's been within the last few hours, if they could potentially benefit from this medication, I would encourage to give it, as it obviously could be potentially life-saving for them. We as obstetricians know how to treat bleeding from the uterus or bleeding from a wound if we need to, but if patients need their hearts, obviously, and so if they can benefit from a fibrinolytic, they should get it. So I'm sorry if this looks really small, but this is just another algorithm. I like maps and I like arrows. And so it makes what should be complex management a little more straightforward to do. Once again, it's decision points of what kind of MI do you think the patient has and sort of what their risk stratification is as it relates to myocardial infarction. So I'll explain that in the next slide. But basically the decisions to be made are, can the patient be managed medically, or does she need a percutaneous coronary intervention? And that's what this risk assessment is about. And also, at what point to decide, does she need to be transferred, or can she continue to be managed where she is? So these are the risk scores. And my understanding of these is fairly shallow, I will admit, but it seems pretty straightforward to me. So basically, this is to help decide, can the patient be managed medically, or does she need to go to the cath lab? And these are not specific to pregnant women, as you can tell by the risk factors. We don't have many age over 65 pregnant women, thank goodness. But there are other things here that I think could potentially apply. Do they have coronary artery disease risk factors? Do they have known disease? Have they had aspirin? Do they have angina? What does their creatinine and EKG look like? So these help a little bit, I think, but once again, you're going to be, as an obstetrician, which I know I presume not everybody in the room is one, making this in concert with your cardiologist or ER physician. So delivery planning in these patients, if they're still pregnant, if they're prior to 34 weeks, I would recommend giving them betamethasone. In general, there's been this longstanding recommendation in the OB and MFM literature to avoid delivery for 2 weeks, which is a completely arbitrary cutoff. But I think the logic is reasonable. You're trying to avoid putting extra stress on the heart that is damaged with delivery. Pregnancy in general is sort of the ultimate stress test for the heart based on all the cardiac changes and physiologic changes that a woman goes through. But then to add the additional stress of labor and delivery or a C-section onto that, it seems reasonable to me to avoid that for a period of time. That being said, these patients can still labor and deliver vaginally. They only need a C-section for appropriate obstetric indications. Pain control is paramount in these patients, and that's when the anesthesia friend is your best friend. They would recommend supplemental oxygen in the course of labor to maximize oxygen delivery to the heart, and to consider a passive second stage, which means to not let them push. So to dose their epidural dense enough so that they're comfortable, let the labor do the work with the help of some oxytocin to bring the baby down low enough into the vagina to either deliver with vacuum or forceps. So, and finally, I wanted to talk a little bit about influenza. I know this is not a rare outcome, but we are deep into the influenza season. And now there is this new respiratory virus called a coronavirus variant from China that some of you may have heard about, which also can present with symptoms similar to influenza. We got a special bulletin in our email here today about assessing patients for anybody that potentially comes from China, if they have any of these types of symptoms, particularly the area of China where this virus is from, to make sure they are isolated to prevent transmission. So our case is a 24-year-old patient, G2P1 at 23 weeks, who calls the clinic with a 2-day history of fever, dry cough, body aches, and malaise. She kind of read the textbook on influenza. But now what made her call today is that she's short of breath and she can hardly complete a sentence. She tells your nurse that she didn't get a flu shot because she doesn't believe in flu vaccines. And she also has a history of asthma. So as everybody should be aware, it's recommended that pregnant women receive the flu vaccine, both for the benefit of the newborn due to passive immunization from mom, but also for maternal benefit, because we know, that pregnant women who get influenza are much higher risk for complications related to the flu. They are more likely to develop pneumonia, require hospitalization and ICU admission. They're also more likely to go into preterm labor and have a higher risk of maternal mortality. And once again, our patients are more complicated. They have more underlying comorbidities, which also puts them at risk for complications related to flu. So another busy algorithm in arrows, I'm going to enlarge it and break it down for you. But this is from an ACOG SMFM joint guideline on patients with suspected or confirmed influenza. And the goal of this document is to be used to help physicians' offices use it for telephone triage. You want to evaluate patients if they have influenza, but you also want to limit their exposure to other pregnant women who could potentially contract it from them. So that's a lot of sort of the themes in this document. The other theme in this document is to not rely on testing before treatment. You should treat these patients presumptively based on their symptoms, and just to reinforce the idea that antivirals for influenza are safe throughout pregnancy. So the patient calls your phone triage in your clinic, talks to one of your nurses, and if she reports any of the symptoms in this box, that the person on the phone should then proceed down the algorithm. Obviously, if they don't have those signs, they should just have routine prenatal care. Even if the patient doesn't report fever but has other symptoms, you should still proceed with the algorithm. So the next point is to see how bad the patient's symptoms are, as to whether or not she needs to be admitted or seen emergently, either in the emergency department or labor and delivery, depending on where you practice. Once again, the point is made to make sure she can be isolated, to avoid exposing other patients who could be at risk. But, is she short of breath? Does she have pain in her chest? Is she dehydrated? Does she have some mental status changes? Those all would warrant, an emergent evaluation, and to start treatment as soon as possible. If she doesn't answer any of those questions in the affirmative, the next assessment is what are her clinical and social risks, meaning does she have other potential risk factors that she could deteriorate quickly or is she unable to care for herself or able to get to the hospital or the clinic if she needs to be seen? If she has positive answers to any of those questions, that you could be seen in an ambulatory setting as long as they're able to perform the evaluation needed, and once again, where she can be isolated. An evaluation includes physical exam and tests such as pulse oximetry, chest x-ray, or ABG as needed, and once again, to start treatment as soon as possible. If the patient makes it through that hurdle, then she can begin antiviral treatment as prescribed over the phone. And then she should be given precautions about what signs and symptoms to watch for, and then to plan to follow up in a day or two to see how she's doing. So just to reinforce this idea that you can treat patients as outpatients by symptoms alone, the anti-influenza antivirals are safe in pregnancy. Oseltamivir can be given twice a day for 5 days. There is a meter dose inhaler and an IV form of these medications as well, depending on the patient's ability to take pills. They can take Tylenol as needed. They should be encouraged to hydrate PO as much as possible. And you can certainly test them for influenza, but once again, don't wait until the test returns before treating them presumptively. If a patient calls and says she's been exposed to somebody with flu, she can take prophylactic doses of oseltamivir, 1 pill once a day for 7 to 10 days. If your patient needs to be admitted, a CBC is important, and blood gas if her oxygen saturation is less than 95% on room air. Or if you're unable to get her oxygen saturation above that with oxygen, I'd recommend a chest x-ray to look for secondary pneumonia. These patients often come in very dehydrated, and so to give them IV fluids, oxygen is needed, antibiotics and nebulizer treatments or steroids if they have asthma should be started, and if they're beyond 24 weeks, to monitor the fetus and the uterus. I talk a lot about oxygen saturations and treatments because in my experience, sometimes our non-OB physician friends will tolerate a lower oxygen saturation in a non-pregnant adult than we can tolerate in a pregnant woman. So those ABGs listed there are normal for pregnancy and a fetus. And to reinforce to you that the fetal oxygen dissociation curve is more steep and shifted to, shifted to the left. And what that means is that small changes in maternal oxygenation can affect the fetus largely. So if mom is way out here, the baby is also way out here. But if mom's, PO2 is 60, then, the fetal PO2 is low as well. So it's what I always advise when our patients are in the ICU or even on a non-OB floor is to try and keep the maternal oxygen saturation above 95 or 96%, and that is to avoid fetal acidosis. The other thing to keep in mind is that women who are pregnant women who are hypoxemic for a long period of time also are more likely to go into labor because the myometrium is also sensitive to oxygen levels. So if it's not getting adequate oxygenation, they may start to contract. I would recommend considering transfer of these patients to a higher level center if they are at risk for respiratory failure. It's less complicated to transfer a patient if they're not intubated, but it certainly can be done as necessary. You need to treat the patient as she needs at the time. And also if you're concerned about preterm labor, transfer earlier rather than later is also important. So in summary, the take-home points for you all is that our pregnant patients are more complex and higher risk than they have been in the past. I want you to think a little bit like an MFM when you're seeing a patient at her new OB visit and assess her medical risk factors and potential complications in pregnancy. I'm not trying to make every pregnant lady abnormal and high risk. I have plenty to do, but I feel like thinking a little bit about it on the front end is important. And it's important to reinforce to everybody to treat the pregnant women as much as or similar to a non-pregnant woman. When you look at studies for women who have non-obstetric complications in pregnancy, one of the risk factors that for potential poor outcome is delay in treatment. Because some people panic, think, oh my God, this is a pregnant woman, I can't do stuff to her. That's when OB is needed, because we can help reassure you that yes, you can treat this woman the same, and it's important that you treat this pregnant woman the same so that she has as good an outcome as a non-pregnant woman would. It's important to be familiar with your capabilities for acutely ill patients at your hospital, and when transfer is indicated to optimize outcome for mom and baby. So I thank you for your attention. And once again, my apologies for not being there in person. I'm happy to answer any questions. And here's my email. Please reach out if you have any other questions or concerns. Thank you very much. Does anybody have any questions?
I have a question in regards to the lady who strokes in the setting of preeclampsia. At what level of blood pressure do you aim for before you would consider delivery?
So, I mean, if somebody is, are you talking about in that patient in particular?
Yes, in the preeclamptic patient who strokes.
I mean, if they are consistently 160 over 100 and I cannot bring their blood pressure down with standard therapies, either, IV labetalol or IV hydralazine, particularly if they're near term or term, then I would move towards delivery. Does that answer your question?
Yes.
Okay.
I have a question about the number of OB-GYN available in the state. I understand Iowa is last in the number of OB-GYNs per population, and I know there have been a lot of closures. For example, the Washington, Iowa closure was in part due to a huge medical malpractice case. So can you tell us a little bit about how you think the state can overcome the shortage of OBs and the OB delivery locations? We've lost some in Webster City and Iowa Falls recently here too.
The short answer is if I could answer that question, I probably could run for governor. But I think that there are a number of things. I think it's hard for these smaller towns and these hospitals to support, an OBGYN practice. It's expensive to run obstetric services for a hospital. Labor and deliveries are expensive. They require staff and supplies to be available 24/7. That's a lot of overhead. I think improving reimbursement to these smaller hospitals is important. I think that we could do more as the tertiary centers to help support them. That's part of what we're trying to do with the Maternal Health Innovation Grant we were awarded last fall, is try to, how we can better improve networks of support among these small hospitals, helping the local providers, be prepared and just set up more avenues of communication with us and referral and transfer if needed. I think there is a perception that Iowa is rural and there's not much going on here, and that living here is not as fabulous as it is on the coast. So I think there's some lifestyle issues that I think we need to, biases that we can overcome, and I'm not sure how to do that. I think that the medical malpractice climate in Iowa is becoming a bit more hostile to OB. The abortion question and debate in this state plays a big role if we're in some OBGYNs choice of where they live and practice. So there are a number of issues. Obviously, I don't have the magic bullet. I think this crisis that we're experiencing in our state has been developing over a long period of time and wasn't really, in my opinion, addressed adequately. And now it's at a crisis level. And so we're trying to fix lots of things all at the same time. It's hard to fix a complicated problem in a short period of time that developed over many years.
Dr. Greiner, do you see mothers with the elevated bile salts issues, the itchy mama?
The moms with cholestasis of pregnancy, yes, we do see those patients.
I have one that's local that is trying to make sure that she doesn't have to travel far for treatment.
So are you saying does she want to be seen for a consult? Is that what you're asking? I guess I'm not sure what your question is.
Well, I think she's trying to establish support here so that she can remain local as opposed to traveling to Mayo where she's been when she is not pregnant with it.
Oh, okay. Oh, so she has cholestasis outside of pregnancy?
I believe so, yes.
Oh, okay. Yeah, I mean, we would see her here and certainly could try to co-manage her pregnancy with her provider there. We've done that in other scenarios. If this is closer for her, those kinds of conditions don't, like that one in particular, probably wouldn't really affect her delivery timing and outcome. I mean, we might make recommendations about when she should be delivered, but how she doesn't need an MFM to deliver her. But we could certainly make recommendations on pregnancy management and have some visits here and some visits there. That's certainly possible.
Thank you. We're looking for options.
All right. Just reach out. I'll be happy to help.
I think that's the end of our questions. Thank you so much.
All right. Thanks, everybody. Have a good day. Stay safe.